So I am very pleased to have Dr. Sarah Adams with us tonight as our speaker. Dr. Adams is a gynecologic oncologist who joined the faculty of the University of New Mexico Cancer Center in 2012, where she is an assistant professor of obstetrics and gynecology and the Surface Professor in Ovarian Cancer Research. Previously, she was on faculty at the University of Pennsylvania, where she also completed her gynecologic oncology fellowship. Her undergraduate degree is from Harvard, and she completed her medical school and a residency in obstetrics and gynecology at the University of Chicago. In addition to being a skilled physician, Dr. Adams is also an accomplished researcher. She is a recipient of OCRFA's prestigious Liz Tilberis Award, and has been awarded grants from many other funding agencies as well. And Dr. Adams generously donates her time to our cause and has spoken at many of our ovarian cancer national conferences, where her sessions are always a hit. So, Dr. Adams, I will pass the presentation over to you, and you can share your presentation and we can get started.
Okay, can you hear me?
Yes, I can.
And can you see the presentation?
We can.
Excellent.
That looks great.
All right. Thanks, everybody. I'm happy to give this talk again. And please, if I'm speaking too quickly or if you can't hear me, type in a question so Sarah can let me know. As she said, I'm at the University of New Mexico now, and I've put some pictures of New Mexico in the talk just because it's so beautiful out here. And I'll be talking today about ways to manage recurrent ovarian cancer. As Sarah said, I have research support from the Ovarian Cancer Research Fund and from other foundations, and I'm running a clinical trial that's currently supported by AstraZeneca. And those are the only disclosures that I have. So my goals today are to talk about what the choices are for people with ovarian cancer following recurrence. And to get there, we'll start by talking about the likelihood of recurrence and the symptoms that might suggest recurrent disease. And then we'll talk about how we as clinicians look for recurrence on exam and imaging studies. And then we'll talk for a while about different treatment options, and importantly, what factors go into deciding which treatment option is right for which patient. And finally, I'll talk a little bit about clinical trials, because I think they're a good way to expand treatment options for a lot of people, but there are a lot of important things to consider if you're thinking about enrolling in a clinical trial. Just to be clear, most of what I'm talking about is based on research done in women with epithelial ovarian cancer, because this is the most common kind of ovarian cancer, and it's usually what people are referring to when they talk about ovarian cancer. Excuse me. There are other kinds of ovarian cancers that arise from the germ cells or from the stromal cells of the ovary, but they're much less common, and so there's less data about the kinds of treatments that are appropriate for those tumors, and a lot of it's actually been adapted from data from studies of women with epithelial cancers. In addition, as you know, there are different kinds of epithelial cancers, and again, the majority of those are serous cancers. We've recognized more and more recently that serous cancers and mucinous cancers behave differently, and it may be appropriate to treat them differently. But I'll be talking about general principles in the treatment of ovarian cancer recurrence that apply to all of these types, but just recognize that most ovarian cancers of the serous subtype, and so most of the data that we'll be talking about is primarily derived from groups of people with serous cancers. And finally, just to review, as most people know, primary treatment for ovarian cancer usually includes surgery and chemotherapy in some combination. Sometimes people get surgery first, followed by adjuvant chemotherapy, and sometimes, and more often now, people might get chemotherapy first with interval surgery and then completion chemotherapy following surgery. And after completion of primary treatment, some people continue with something called maintenance therapy. These days, that's most often with Avastin, or in some clinical trials, maybe with a PARP inhibitor, with the idea that ongoing treatment might reduce the risk of cancer recurrence. And then during maintenance and after completion of primary treatment, people are usually monitored with some schedule of cancer surveillance, often visits every 3 months for the first couple of years and then spacing out those visits as the time goes on. Importantly, the goal of this part of ovarian cancer is curative. And the reason the treatment is so aggressive is because we think this is the best chance we have to cure a woman of her cancer. And so we think the toxicity of treatment is counterbalanced by the potential benefit of this aggressive regimen of surgery and chemotherapy. So the first question is, what are the chances that ovarian cancer will return after this initial treatment? And unfortunately, although most people respond to chemotherapy and respond to primary treatment, the likelihood of recurrence for women with ovarian cancer is quite high. Shown here is the likelihood of recurrence stratified by stage of disease, and stage 3 is subdivided based on whether someone was optimally debulked or suboptimally debulked at the time of surgery. And you can see that the majority of women ultimately do experience cancer recurrence, especially since most women are diagnosed in stage 3 or stage 4 with stage 3 or stage 4 disease, and so the recurrence rate is quite high there. And so if the likelihood of recurrence is high, how does somebody know that she has a recurrence? And what symptoms should a person look for that might suggest recurrent disease? And this is also a little bit difficult. Ovarian cancer is notorious for being difficult to diagnose because the symptoms that people present with can be quite vague. And so there's a campaign about ovarian cancer symptoms with the idea that it whispers, so we should be attentive to symptoms like bloating or pelvic pain or early satiety. And as most people know, that leads oftentimes to incorrect diagnosis or a big workup before somebody considers ovarian cancer. The same problem exists with recurrent disease. Because the cancer tends to come back inside the abdominal cavity, a lot of times people will present with similar symptoms. Depending on whether the tumor recurs, they might have a change in their bowel or bladder habits or bloating. They might have pain. If they have a recurrence of fluid in the lungs or pulmonary disease, they might have shortness of breath. They might have nausea or vomiting. And so usually I tell people that it's important to communicate with their oncologist and report any new symptoms that they experience to decide whether it's something worth following up on. In a woman who has a history of ovarian cancer who presents with new symptoms, there's usually a sequential workup to decide if the symptoms are related to cancer recurrence. And the way we do that is to examine people, to look for evidence of fluid in the lungs or enlargement of the lymph nodes. And we often do pelvic exams because they allow us to palpate the lining of the abdominal cavity to feel for peritoneal disease. Unfortunately, because the disease tends to recur in the abdominal cavity, a lot of times an exam can be very normal in someone who does have recurrence, just because the tumor is in a place that's not accessible to us on exam. The other way we screen people for recurrence is to use CA-125, which is the tumor marker that's been validated in women with ovarian cancer. Although CA-125 is not a great test for diagnosing cancer initially or for screening people for ovarian cancer, it is very helpful in women with an ovarian cancer diagnosis to monitor for cancer recurrence. And usually in somebody who's had a history of ovarian cancer, a rise in CA-125 likely means that the cancer is returned. It's definitely true that CA-125 can be elevated with other conditions, inflammatory conditions or infections. But if the CA-125 level continues to rise, it's very likely that there's, or people will most likely be concerned about cancer recurrence and require some further workup to rule that out. Usually the way that recurrences are diagnosed are with imaging studies, and most commonly people have CAT scans or MRIs depending on the person and what you're looking for. Different imaging studies have different sensitivities for diagnosing cancer recurrence, and part of the difficulty is that ovarian cancer can come back as kind of small volume peritoneal disease that looks like little grains of cancer that line the abdominal cavity. And we know from surgery when we see that it doesn't always show up on a CAT scan. So sometimes it's hard to find that pattern of recurrence. If there's uncertainty about whether something found on imaging is indeed recurrence, people may be biopsied to get tissue for a histologic diagnosis. And so here's the crux of the talk. If a recurrence is diagnosed, what options are available to somebody, and how do you decide which option to pursue? So as I told you, the treatment goal for primary treatment for ovarian cancer is curative, and the approach is very aggressive for that reason. In recurrent disease, there's no longer the same likelihood that somebody will be cured, and so the risk-benefit balance changes significantly, and the goal of treatment is both to prolong disease-free and overall survival, but also to palliate symptoms and maintain quality of life. There are a lot of options to treat recurrent ovarian cancer, and those include surgery or chemotherapy. We'll also talk a little bit about targeted therapeutics, immune therapy, hormone therapy, radiation, and the option of observation or ongoing surveillance. The role of surgery in the management of recurrent ovarian cancer is still under investigation. And the reason is that it's difficult to design studies to isolate the effect of surgery on recurrent disease, because it's hard to design studies where people are randomized to get surgery or not get surgery. But there are some of those going on right now to try to answer this question, because it's an important question in ovarian cancer management. Because surgery is so important in the primary treatment of ovarian cancer, and we think that it sensitizes people to chemotherapy following tumor debulking, there's a lot of interest in offering people surgery for recurrent disease. However, when people have cancer recurrence, it's a little bit more difficult to select people for surgery, and their general health may be a little bit different than it was when they were first diagnosed. And so the information we have suggests that the people who are likely to benefit the most from surgery are those who have platinum-sensitive disease, and we'll define that in a minute. People who have limited sites of recurrence, people who have long treatment-free intervals between the completion of their first chemotherapy and the diagnosis of recurrence, people who do not have ascites, and people who are overall healthy. And the reason why that makes it difficult to decide how much surgery helps people is that those are all features of people with a better prognosis at baseline. In general, people who have surgery for recurrent disease have the same goals from surgery as people who have upfront surgery, which is to remove all the tumor bulk to get rid of all gross disease at the time of recurrence. And when that's possible, people get the maximal benefit from surgery. The other role for surgery in recurrent disease is to palliate symptoms. So in a person who has a bowel obstruction, for example, surgery might help relieve that obstruction. And that's a different role for surgery than tumor debulking and preparation for ongoing chemotherapy. Lastly, usually minimally invasive surgery isn't used up front for ovarian cancer, although its role is growing. But when people have recurrent disease, minimally invasive options may be available to them to limit the morbidity of surgical resection. Most women with ovarian cancer recurrences are treated with chemotherapy, and most people respond to second-line chemotherapy. A person's response to treatment of recurrent disease is predicted by a couple of things. One is the characteristic of the tumor that she has, meaning what histologic subtype she had to begin with, how much tumor is evident at the time of diagnosis of recurrence, and the number of disease sites. In addition, as we spoke about in passing, the duration of response to previous chemotherapy can predict how well somebody's going to respond to second-line chemotherapy. And that's called the treatment-free interval or the platinum-free interval. And so the longer someone's gone without treatment before she's diagnosed with a recurrence, the more likely it is that she'll respond to second-line chemotherapy. This issue of platinum sensitivity is really central to the treatment of ovarian cancer because it stratifies people into groups expected to do better and in whom we feel the toxicity of ongoing treatment is worth the potential benefit, and people who are less likely to do well and in whom we want to focus more on quality of life and limiting toxicity. Most women with ovarian cancer do respond to platinum agents up front, and the time to recurrence after platinum treatment is what's described as platinum sensitivity. So a person who's considered platinum sensitive is someone who's gone greater than 6 months without a cancer recurrence following treatment with a platinum agent. And because they're sensitive to platinum agents, usually recurrent disease is treated with another platinum agent or with the same one they received previously, and often in combination with another drug. People who are platinum resistant are people who respond to platinum but then are diagnosed with a recurrence within 6 months of completion of treatment. And often those people are treated with a non-platinum drug with the idea that their response to platinum was limited and we should consider other options. And other chemotherapeutics that are used for ovarian cancer include Doxil or Taxol, Gemzar, or topotecan. And finally, someone who's described as platinum refractory is someone who either didn't achieve remission or exhibited disease progression during treatment with a platinum agent. And they're also treated with something other than a platinum agent if they respond or at the time of disease progression. The reason platinum sensitivity is important is that, as I said, it stratifies people into groups that are expected to respond well and expected to have better outcomes, and those that are expected to have a limited response to second-line chemotherapy. And shown here are the responses of people in several very large clinical trials. These are all platinum-sensitive patients, and these trials are all comparing some platinum combination in the ICON-4 trial, carboplatin versus carbo plus Taxol. And shown are the response rates of the women in each of these groups. You can see that the response rates of platinum-sensitive patients approach 80%, which is about what we would expect in response to frontline therapy for women newly diagnosed with ovarian cancer. And similarly, the survival after treatment, the median progression-free survival in these women is on average about a year, which is more than would be expected in somebody who was platinum-resistant or refractory. Shown here are the agents that we use that are not platinum agents, and so they're most commonly used in platinum-resistant disease. And you can see the different response rates associated with each of the agents. Because platinum-resistant or platinum-refractory disease is less responsive to chemotherapy, in general, people are treated with just single-agent regimens so that they don't accumulate the toxicity of combined treatment with limited expectation of benefit. Besides chemotherapy, there are several targeted agents that are currently being used in ovarian cancer, and these have some distinct advantages. The toxicity profile of targeted agents is often different than the toxicity profile associated with chemotherapy. And so in someone who might have residual neuropathy from Taxol therapy, being treated with something that is unlikely to cause that same symptom may allow her to be treated with full-dose therapy and to complete a treatment regimen. In addition, targeted agents may be active in chemotherapy-resistant disease, and in most cases, we have a better understanding of their mechanism of action. The two targeted agents that have been used the most in ovarian cancer are Avastin or bevacizumab, which is the antibody to the vascular endothelial growth factor. This antibody acts by blocking blood vessel formation, which starves the tumor of oxygen and nutrients. And emerging evidence suggests that this agent also has immunomodulatory effects that may be beneficial to people. The response to Avastin has been quite good. In most studies, it's greater than 20%. And unlike chemotherapy, Avastin seems to be very well tolerated, even in people who've had multiple chemotherapy regimens in the past. And so this is a very appealing way to treat recurrent ovarian cancer. And it's one that I use a lot because people can be maintained on it for a long time without significant compromise in their quality of life. The other targeted agent that's been used in ovarian cancer is a PARP inhibitor, which blocks an enzyme that's responsible for single-stranded DNA repair. This has been very successful in the treatment of cancers associated with BRCA1 or BRCA2 gene mutations, and that's because those mutations are responsible for a different DNA repair pathway. So treating patients who lack one mechanism of DNA repair with something that blocks an alternate mechanism results in specific death of the tumor cells and largely leaves other cells untouched. The response rates to this agent have been very high, and it's a very well-tolerated approach to treatment because it's an oral pill that people can take at home. And they don't tend to have the same types of toxicity associated with cytotoxic or chemotherapeutic drugs. Hormone therapy is used sometimes in ovarian cancer. It's not usually a first-line treatment or even usually a second-line treatment for most people because the response rates and the ability of this to make tumors regress is fairly limited. But it has some advantages, and those include the lower toxicity associated with hormone therapy and the fact that it's usually an oral agent that people can take at home. Agents that have been used include tamoxifen and some of the selective estrogen receptor modulators, as well as now aromatase inhibitors, with response rates in the 10% range, sometimes up to 20%. And in best case scenario, they often maintain people with stable disease for some time. The one area where aromatase inhibitors have been very successful lately or have generated interest recently is in the treatment of low-grade serous cancers, with evidence that aromatase inhibitors may be a good strategy even for frontline treatment in those tumors. Radiation or radiotherapy is not commonly used for the treatment of ovarian cancer, and that's because the tumor has a tendency to spread through the abdominal cavity, and radiation of the entire abdominal cavity can be very toxic. However, in someone who has an isolated recurrence in her pelvis or the vaginal cuff or maybe on the abdominal wall that can be targeted specifically with radiation, this may be a good strategy to palliate symptoms and to shrink that particular tumor if it's symptomatic. And finally, immune therapy, which has been a big topic in the news lately and has generated a lot of excitement for the treatment of several different types of cancer. And now there's significant interest in adapting the success of this approach to ovarian cancer. Immune therapy has the advantages of having the potential to create an adaptive response to the tumor. By educating your body's immune response to recognize cancer, the hope is that if the cancer changes or evolves or mutates, that your body will respond to those changes as well. And it'll be a dynamic interaction between your immune system and the cancer. The other advantage is that immune therapy may have the potential to create immune memory, just like a vaccine does, so that if the cancer recurs, your body will recognize that recurrence and attack the recurrent disease, providing long-lasting protection to people. Finally, the toxicity profile of immune therapy is a lot different than the toxicities associated with chemotherapy. Unfortunately, sometimes the toxicities can be quite severe, but they're mediated by a very different mechanism than chemotherapy toxicity. And usually they're associated with overactive immune responses to healthy tissues. And so as immune therapy has been used more and more, people have understood this difference, and methods to manage toxicity have become more standardized, and people have been able to tolerate immune therapy better. For ovarian cancer, immune therapy is currently available primarily through clinical trials, but there are a lot of clinical trials for ovarian cancer that are using different strategies for immune therapy. And these include cancer vaccines, something called T-cell therapy, and T-cells are the white blood cells that are responsible for attacking foreign invaders, or in this case, tumors. And then immune checkpoint blockade antibodies, which are the new agents that have shown a great deal of success in melanoma and early evidence of efficacy in ovarian cancer. And there are several clinical trials open now using immune checkpoint antibodies. And lastly, I think it's important to talk about when treatment should be initiated for recurrent disease. And this is something I try to remind myself of when I'm talking to patients. In general, oncologists believe that early diagnosis and treatment of recurrent disease can improve people's outcomes, with the idea that if you find the tumor when it's smaller and before it's symptomatic, you can get a better response to chemotherapy and prevent people from feeling the symptoms associated with large tumor burden. However, a study that was published in 2010 directly addressed this question of whether earlier treatment improved survival, and they also looked at quality of life as an endpoint for the study. And so I'm going to go through this in some detail, only because I think it's important to consider as you're facing decisions about management of recurrent cancer. In this study, 1,400 women were recruited who had responded to primary treatment for ovarian cancer with a complete remission, and who at the time of enrollment had normal CA-125 levels. And they were tested every 3 months for CA-125 levels. And once their tumor marker doubled, they were randomized either into the early treatment group, where they were notified that their CA-125 level doubled and treatment was initiated for recurrent disease, or into what was called the delayed treatment group, in which both the patient and her doctor was blinded to her CA-125 levels. And so cancer recurrence was only diagnosed based on clinical symptoms or findings on exam that suggested recurrence. And these two groups of people were evaluated for the length of treatment-free intervals, their overall survival, and their quality of life. And what the study showed was that there was no difference in overall survival among these two groups. And shown here is a survival curve with the proportion of people surviving on the y-axis and the number of months since enrollment on the x-axis. And you can see that the two graphs completely overlap. This is really kind of shocking. And there are a lot of critiques of the study, but I think it brings up the question about whether it's important to start treatment early or whether balancing someone's goals and wishes about quality of life mean that it's okay to wait a little while before starting chemotherapy once a diagnosis of recurrence is made. Ultimately, the women in the early treatment group in the study underwent more courses of chemotherapy because they were initiated on chemotherapy at an earlier time in their disease course. And the women in the delayed treatment group had a better quality of life, probably because they didn't get as much chemotherapy as the early treatment group. All right, and so the last thing I'd like to talk about is clinical trials and the option of enrolling in a clinical trial as a way of treating recurrent disease. I think that clinical trials are really valuable because I think they offer more options for people who have cancer recurrence. And as a clinician, I'm always glad to have more choices when I'm looking for treatment strategies for someone with recurrent disease. I also think there's benefits to enrolling in a clinical trial because of the structure of clinical trial design and the oversight that's built into clinical trials. So I think having more people paying attention to your progress and concerned about how you're doing is helpful. Just as a quick definition, standard care or standard of care treatment is treatment designed only to treat an individual and to try to make her tumor regress and improve her quality of life. Whereas clinical trials are research, which are designed to test a hypothesis. And in most cases, the hope is that the clinical trial will help the person who's enrolled in it, but not all clinical trials are designed with therapeutic effect as their primary outcome. Early phase clinical trials are designed to evaluate tolerability of a regimen. And it's important to understand if you're considering enrolling in a trial so you know what the investigators are focused on and what the trial has been designed to show. As I said, clinical trials have a lot of oversight built into them. They are all approved by an institutional review board, which is tasked with protecting the rights and welfare of people who enroll in these trials. And these boards include members of the community. They also are voluntary, and the voluntary nature of them is central to the whole idea of clinical research. And they require, as a result, informed consent by each participant. They're characterized by some strategies that are designed to optimize results. The ones that are best known are randomization, where a subject may not know which treatment she's getting, or she may not get a choice which treatment group she's enrolled in. And then blinding is the part where she doesn't know, and maybe her physician also doesn't know whether she's getting an active treatment or a placebo. As I said, the goals of different phases of clinical trials are different, and it's important to understand if you're considering them. Phase 1 trials are designed to evaluate safety and tolerability of a potential treatment regimen. They're usually not controlled, and they're usually not blinded because these are small studies that enroll usually 3 people on a particular regimen, and then those 3 are watched to see if they have any side effects, and then 3 more people are enrolled and 3 more people are enrolled, often at escalating doses to evaluate for the maximally tolerated dose of whatever combination is being studied. Because of that, they're not randomized. Everybody who's enrolled is treated, but the person who's enrolling may not know whether she's getting a lower dose or a higher dose, and the doses that people are started on may be lower than expected for efficacy. The next step is a phase 2 trial, which is looking for evidence of an effect, and these may be dose-finding or dose-dependent efficacy trials. Depending on the size of the trials, they may be controlled or uncontrolled. They may be blinded or unblinded. Often these are small trials and they're kind of merged with a phase 1 trial. Or these days there's something called a phase 1-2 trial, where a phase 1 trial rolls into a phase 2 trial. If a particular regimen is found not to be toxic, ongoing enrollment is considered part of phase 2. And so depending on the size of the trial and what's being studied, they may or may not be randomized. And finally, the phase 3 trials are the big trials looking for a therapeutic effect or a therapeutic ratio, usually comparing a new regimen with a standard of care regimen. In cancer trials, the control is usually standard of care with a placebo compared with standard of care with the active agent. It's very uncommon to have somebody enrolled in a cancer trial who's getting only a placebo. And these are the trials that might be blinded and are often randomized to avoid bias in interpretation of the results. And lastly, there's something called a phase 4 trial, which is just post-marketing surveillance, which is ongoing oversight of the use of these agents, looking for safety signals as more and more people are using them. As I said, I think there are a lot of benefits of enrolling in clinical trials, but the advantages and disadvantages are different for the different phases of the trials. Phase 1 trials may offer access to some of the newest therapeutic agents. These days, there's some phase 1 trials of immune therapy, there's some vaccine trials, there's some combination trials using immune therapy, drugs in combination for ovarian cancer. Some people think it's an advantage that these are usually not randomized and they're not blinded. And since these are smaller studies, the results may be available sooner to give people information about the agent that was being tested. Disadvantages of a phase 1 trial include the fact that most of them involve some sort of dose escalation to look for toxicity. And so that means that the first people enrolled may be given a dose that's lower than is expected to be efficacious. Also, the primary outcomes are safety and tolerability, not efficacy. And so the trial isn't designed to evaluate how well the treatment works. And then this approach may or may not be administered in combination with known active agents. So people may only be getting a study drug without a drug that we know will work in the treatment of cancer. And so these trials are often open to people with different tumor types and often have more relaxed enrollment criteria because they're used commonly in people who no longer qualify for some of the larger phase 3 trials. In contrast to phase 1, the phase 3 trials are using a regimen that's already been tested in prior phase 1 and 2, so it must have shown some evidence of efficacy to be advanced to a phase 3 study. These tend to be very large, very expensive trials, and so the selection process on the way to a phase 3 trial usually means that there's been enough of a signal that people think it's worth investing in a phase 3 trial. As I said earlier, these agents are often given with active agents. An example would be the carboplatin Taxol and Avastin versus the carboplatin Taxol and placebo trial that was run a few years ago to evaluate the efficacy of Avastin in frontline treatment of ovarian cancer. These are often randomized, are often blinded, which some people see as a disadvantage and which some people find a little bit disconcerting. And because they're such large studies, it can take years to learn the results and to get information from the trials. In addition to those individual benefits, though, there's additional benefits to patients or subjects. And as I said, I think that it's helpful to have oversight by a team of physicians that includes study personnel, nurses, and both local and national study management. I think that they're very helpful because they do expand the options for treatment. And there's, of course, a benefit to other women with ovarian cancer through the advancement of our understanding of treatment options and tumor biology. I think if a person's considering enrolling in a clinical trial, it's important to feel empowered to ask any questions that you have. And here's a list of some questions you might consider if you're considering a trial versus a standard of care treatment. I think it's important to understand the goals of the trial, to understand what additional tests will be required of you, which are voluntary and which are required for enrollment in the trial, and what the measure of efficacy is. And all of those are questions that should be reviewed with you as you're going through the informed consent process. And so to summarize what I've said so far, what I hope I've conveyed is that there are many options available to manage ovarian cancer recurrence. And several factors affect the choice of treatment, including a person's symptoms, her response to prior treatment, the availability of clinical trials at her hospital or in her area, and patient preference. So one of the questions that popped up while we were waiting to start was whether it's legitimate to pick a regimen to avoid losing your hair. And I would say yes. I think that's a very valid reason for selecting one treatment regimen over another. Or, for example, if someone has persistent neuropathy, that would dictate which chemotherapeutics would be good choices for her and which would probably not be good choices for her. But the goal of treatment for all of this is to optimize a person's quality of life and to prolong her remission. And so there's lots of places to go for information about clinical trials. This is the old website from OCRF, but I'm sure that the Merged Alliance has a website with clinical trial information on it. And you can also go to clinicaltrials.gov to learn about clinical trials. And that's the end of my talk. I'm happy to take any questions.
Great. Dr. Adams, thank you very much. That was excellent. A ton of great information, and we have a lot of questions. So I'm going to try to kind of group them together as best I can, but I'm just going to try to get through some of them. A few questions came in about that 2010 study that you showed with the two curves aligning, relating to the delaying of treatment. Questions are, why does finding the treatment, why doesn't finding it earlier not lead to a better outcome? And in your clinical practice, have you witnessed confirmation of that study?
So those are hard questions to answer.
Yeah.
That's okay. So just to be fair, there's criticism of that study. It was conducted in Europe, and the concern was that maybe frontline treatment for people in Europe may not be as aggressive as it is typically here, and that maybe that makes a difference. The Society of GYN Oncology here in the States recommends ongoing CA-125 surveillance, which is the way that people were being monitored and stratified in that trial. Reasons why the survival might not be different are hard to decide, but among the possible explanations are that chemotherapy-resistant disease develops in response to treatment, and so ongoing exposure to chemotherapy may kill off the sensitive portion of the tumor, but you may continue to develop treatment resistance after exposure to multiple agents. Another reason might be just that chemotherapy wears people down, and people often aren't as healthy when they're on chemotherapy than when they're off chemotherapy, and that can contribute to someone's overall quality of life, certainly, but also prognosis. And as to whether I've seen that in my own practice, it's hard to measure on an individual patient basis, but I've definitely had patients who decided that they felt pretty good. They didn't have any symptoms from their tumor, and they knew that they were definitely going to have symptoms from chemotherapy, and so they decided to forego chemotherapy. And what we do in those cases is we continue to monitor CA-125 and usually monitor imaging studies every 3 or 6 months just to see what the progress of the tumor is. And sometimes people decide they're just really uncomfortable not treating a tumor and knowing it's there. But other times, if the tumor is growing slowly and the person remains overall asymptomatic, we'll continue to just watch. And what's hard, for me anyway, is that it's hard to know whose tumor is going to grow fast and whose tumor is going to grow slowly, and who can wait for a long time and expect that her quality of life will be maintained.
Okay, thank you. I know that's a tricky question. Just to jump to sort of some clinical question here, what is the most likely place for a recurrence? Abdomen, is it likely to go to the lungs?
So ovarian cancer is characterized by spread through the peritoneal cavity in the abdomen, and recurrent disease primarily is found in the peritoneal cavity as well. The exception to that is women who've had intraperitoneal chemotherapy seem to have their recurrences diagnosed outside of the peritoneal cavity, more commonly the women who did not have IP chemo. And so the places outside of the peritoneal cavity where you might find recurrences in the lungs, oftentimes with pleural effusions, or in the lymph nodes in the abdomen or pelvis.
Okay, thank you. This is another sort of tough general question, but I think it's probably something that many people think about. This woman says, I'm at a crossroads here. This round of treatment that I'm having now is the worst I've had. I know it's going to give me more time, but how do I know when to stop? Basically, what do you do when you're worried that the chemo may be sort of, causing more harm than it is doing good? What do you say to patients who are facing that dilemma?
That's really hard, and it's a hard decision to make. And so I recently discussed this with a patient I was caring for about whether she should come off of a clinical trial or not. And where it's difficult is it's hard to know if a different regimen is going to be better than the one that she's on, and it's hard to know who's going to respond to which agent. So when I told you that there was a 20% response rate, we don't know who's in the 20% group and who's in the 80% group. And so usually what I tell people is, unless it's a clinical trial, decisions about staying on staying on treatment or going off treatment aren't really irreversible. If somebody comes off treatment and decides to wait and see how she does without treatment for a couple of months, we can always restart treatment if we need to. Similarly, if someone decides to stay on and they don't start to feel better, we can certainly stop. And so if we're planning 6 cycles of treatment for recurrent disease, I'll usually do a CT scan after 3 to look for evidence of response. And I usually want to see that something's helping someone to rationalize continuing it and putting somebody through the toxicity of treatment. And so if you're having a lot of toxicity from a regimen, but you're also seeing a lot of benefit and your tumor's shrinking, then you might be willing to continue despite the toxicity. But if you're having a lot of toxicity and you get a CAT scan, it really doesn't seem like things are changing very much, or certainly if you see progression despite treatment, then it seems like that would be a time to change.
Okay, thank you. You mentioned scans. We had a few questions about CT scan versus PET scan. Questions are CT scans the best? Why do doctors seem to prefer them over PET scans? Also, what is the sort of safe limit for the number of imaging tests you can get per year, for example?
I don't know the answer to the second question. A radiologist would, but I think in general the risk of leukemia and second cancers is quite low. As far as which modality is best, I know some people use PET scans. We don't here usually, unless there's some doubt about whether a mass that we see might be cancer, might be something else. So in other diseases that we treat with radiation, where there might be a residual mass that's not an active tumor, then a PET scan is helpful. But in ovarian cancer, if the cancer comes back and forms a mass, you can usually see that on a CT scan, and that's sufficient for monitoring disease and diagnosing recurrence.
Okay, great. Thank you. Let's talk a little bit about immunotherapy. So you mentioned immunotherapy. We had some questions about it. Overall, how good would you say the evidence is that this is going to be a helpful treatment approach for ovarian cancer?
Well, so I should say that my research is focused on immune therapy, so I'm a big fan of immune therapy in theory. I think that ovarian cancer has demonstrated a lot of, there's a lot of rationale for targeting ovarian cancer with immune therapy, but it's not been the first tumor to show success, and a lot of what we're using in ovarian cancer is based on what's been successful in other tumors, and most particularly melanoma. So the rationale for using immune therapy in ovarian cancer is based on a study done in 2003 by George Kukos showing that people who have spontaneous immune responses to their tumors have better survival. And so the thinking is that if we could induce an immune response or amplify an immune response, we could improve people's survival. And that's been done, as I said, in several ways, using vaccines and using what's called adoptive T-cell therapy, which is infusing tumor-specific T-cells into a patient, and now with these immune checkpoint inhibitors. And so some of the difficulties with immune therapy, or at least with those earlier strategies, the vaccine and the T-cell therapy, is that they aren't things that can be administered everywhere. They require that people get treatment at specialized centers that have the skills and the expertise to administer this kind of therapy. I think a lot of the excitement about immune checkpoint inhibitors is that those are off-the-shelf antibodies that can be administered to people anywhere that they get chemotherapy. And so I think there's a lot of hope that checkpoint inhibitors alone or in combination with chemotherapy will boost the immune response to ovarian cancer and other tumors, and that we can see some of the same successes that have been seen in melanoma. The other thing that's happened recently with the interest in immune therapy is that people have started reevaluating the drugs that we're already using, and they've identified immunomodulatory effects of chemotherapeutics like carboplatin and Taxol. And so I think an awareness of the interactions between the immune system and ovarian cancer, and between the immune system and the drugs that we're using, and a better understanding of those effects will allow us to design combinations and strategies that boost the immune response to the tumor and optimize people's outcomes.
Okay, thank you. We have some questions about PARP inhibitors. So let's see, can you comment on the use of PARP inhibitors for folks who do not have BRCA1 and 2 mutations?
Sure. So there's a lot of interest in treating or in expanding the cohort of people who are eligible for PARP inhibitor therapy or who might benefit from PARP inhibitors. So in addition to people with germline BRCA1 and 2 mutations, there's evidence that sporadic ovarian cancer develops mutations in those genes in the tumor, even though a person doesn't have a germline mutation. And so there's evidence using a couple of different PARP inhibitors that treating people who don't have a germline mutation, you can still see response in a subset of patients. And a couple of different companies are developing tests now to identify those patients so that we know going in who's likely to respond to a PARP inhibitor. So I think there's a lot of excitement about the efficacy of PARP inhibitors and the use of targeted therapy, and the number of people who are eligible for those is growing beyond people with germline BRCA mutations.
Another question about PARPs. If someone's on a clinical trial and one has had disease, or not on the trial, but just is getting a PARP inhibitor and one has had disease progression while on that PARP, would it be reasonable to consider trying a different one?
Yes, potentially. So although all the PARP inhibitors block the PARP enzymes, they have different effects in the cell. And so there's a body of research now looking at how PARP inhibitors affect tumor cells apart from just blocking this PARP enzyme. And it turns out they can glom onto the DNA strand and cause PARP trapping, which is a different mechanism of action. And among the PARP inhibitors from different companies, different ones do that to varying degrees. So I think it'd be worth talking about and considering whether a different PARP inhibitor might be useful, or a PARP inhibitor in combination with something else might be useful after progression on a PARP inhibitor by itself.
Okay, great. Thank you. Okay, let's talk. Okay, question. I'm getting a ton of questions. That's great. In managing recurrence and remission, do the periods of remission typically reduce over time?
Yes. In general, each remission gets shorter and shorter each time. And so some clinical trials and some immune therapy trials have looked at something called remission inversion, which means that a person's remission after treatment is longer than her last remission was, and that's considered evidence of success because it's unusual for that to happen.
And does the age of the patient at recurrence seem to have any bearing on response? Or
not so much age as her performance status. So her general health, I think, is more relevant than her age.
Okay. A little bit about clinical trials. How concerned should a patient with recurrent cancer be about agreeing to a clinical trial, which they might have a chemo drug, which then might later disqualify her from a different clinical trial? How should patients sort of think about navigating those issues?
I don't know. I think it depends on what kind of person you are and how you approach risk and decisions. I think that, or at least when I talk to people, all we know is what we have available at that time. And so if there's a trial that seems like it might help you, I think it's worth considering. It's not, if you enroll in a phase 3 trial, that doesn't mean you can't enroll in a clinical trial down the line. Oftentimes the exclusion criteria have to do with the specific agent being tested. So for example, immune therapy trials sometimes exclude people who've already seen an immune agent in the past because it would muddy their interpretation of the results they might get. But that person might be eligible for a targeted therapy trial or a phase 1 trial down the line. So if you enroll in a clinical trial now, it doesn't mean you can't enroll in a clinical trial later. And if you are treated with standard of care now, that might also exclude you from some clinical trials later. So I think it's worth making the most of the options that are available to you at the time that you're making a decision.
Okay, that's helpful. We have some questions about maintenance therapy. what are your thoughts about maintenance therapy, whether it's with Avastin or PARP? Do you think they're effective? Are there kind of standards, any accepted standards that people should be considering?
So both of those agents have shown prolonged treatment-free survival being used as maintenance therapy. And I think the reason they're successful is because most of the time people feel pretty well while they're on them. Previous studies using maintenance therapy with Taxol did show some benefit, but it's hard to continue to take chemotherapy if you know, at the end of primary treatment, you'd really like to be healthy and not keep coming back for chemotherapy infusions. And I think the advantage of Avastin is that people usually, or bevacizumab, is people usually don't feel sick while they're getting it. And so they're able to work and feel well and continue that as maintenance therapy. Similarly, the PARP inhibitors, while they can cause some nausea and they can cause some drop in people's blood counts, are generally pretty tolerable. And so the minimal risk seems worth the benefit that people have observed in terms of prolonging the time between treatment regimens.
Okay, great. We've had some questions about tumor profiling. Could you speak to the efficacy of it? How useful you think it is at this point in time in terms of helping patients and their physicians think about treatment options?
So I haven't had a lot of luck with tumor profiling, finding things that I can target for people with ovarian cancer. It's been a little bit frustrating. But I think the reason might be just that ovarian cancer is a very heterogeneous cancer. And unlike lung cancer, for example, there aren't as many commonly expressed targetable mutations. We still send people's tumors for profiling, sometimes just to find out if there's anything there that we can treat, and sometimes as part of enrollment in a clinical trial, because some of the targeted therapy trials, some of the phase 1 trials require information about the tumor itself. So I think that that's evolving for ovarian cancer, and I think there's a lot of hope that it can help us select people for treatment better than we have been in the past. But I think it's an emerging technology, and we're just catching up with the treatment options we have for people.
Okay, great. You mentioned at the start of your talk that you were talking about the most common forms of ovarian cancer. We do have some people asking questions about clear cell. Can you make any sort of general comments about how some of the less common forms of ovarian cancer are treated when they recur?
Sure.
Are they similar?
So clear cell is still an epithelial cancer, so it's usually treated frontline with carbo and Taxol or some combination of platinum and taxane. But what we've learned about clear cell cancer is that it has some similarities to renal cell cancer, kidney cancer, and the mutations that drive it. And so sometimes people are treated with some of the targeted agents that have shown success in kidney cancer, for example. And so there's this idea that we might do a better job if we lump cancers based on their mutations instead of based on which organ they came from. And I think that's also a little bit of a moving target or an emerging idea. But with ovarian cancer, we treat, sometimes we treat clear cell a little bit differently than we do serous cancer. We certainly think of mucinous cancers now a little bit differently than we do serous cancers. And I think that there are more trials now that subdivide people based on histology so that we can find out what the best strategies are for these less common types of epithelial cancers.
Right. Okay. Well, we'll start to wrap it up here. One last question. I know some women worry about, is there any evidence to show that receiving either long-term maintenance therapy or just multiple rounds of treatment for recurrent cancer could go on to cause additional different cancer?
Yes, unfortunately. So chemotherapy causes DNA damage, and repeated exposure to agents that cause DNA damage run the risk of secondary malignancies. I've seen this happen in my practice. People can develop leukemias or blood cancers, but it's usually very rare. And when you're faced with a recurrence of the cancer you have, it's hard to know how to incorporate the risk of a cancer you have a small chance of getting in the future when you feel like you need to treat the cancer that you know about. But it is a concern, and the risk is greater with some kinds of chemotherapy than others.
Okay. Dr. Adams, I think we will end it here. Thank you. I want to thank you for the presentation, and I want to thank everybody for calling in today and for all of your wonderful questions. Sorry we couldn't get to them all. Again, a reminder, this is being recorded, so you'll be able to listen to both the audio and to see the slides again. It's going to be available on the OCRFA website starting tomorrow, so we will send everybody an email letting you know when that's available. Thank you again, and please take a minute to fill out the survey that should appear on your screen at the end of the event. Your feedback is always helpful. We're always looking for suggestions for topics for future webinars. And for information about OCRFA, you can always visit our website, www.ocrfa.org. Dr. Adams mentioned clinical trials. We do have a link to a clinical trials navigator, navigation service from our website, which is really helpful. It's a little bit more user-friendly than clinicaltrials.gov. It helps you kind of get to a narrower group of trials that you'd actually be eligible for. So I recommend you check that out if you are interested in a clinical trial. So thank you again, Dr. Adams, and thank you everybody for calling in, and have a great evening.